So good afternoon, and thank you for allowing me to speak in English. My Dutch, unfortunately, is not improving. So as I was introduced, I'm Charmaine Borg, and I work at the University of Groningen, and usually my research focuses on the emotion of disgust and negative emotions in general when we are presented with a sexual stimulus. And I use generally a number of physiological measures to do my experimental designs. Okay, so in the coming few minutes, I'm going to tell something what is sex, but I know that Vogt gave a very good description, an overview of what is sex, but I will take more reductionist approach to see what are the differences between what excites us and what inhibits our sexual approach behavior. And then mention some types that are perhaps, some types of cancer that are perhaps more difficult or more impactful on our sexual experience. And then focus on the psychological impact of cancer. And in this section, I will mention the practical problems, the body image, and also the negative emotionality, which is my main topic. And negative emotions, there are, of course, the fear, anger, depression, and disgust. And disgust is the emotion that we don't really talk about. We hardly have a word for it. But I'm going to talk a little bit about that, and then some interventions or tips that we can use with our clients. As Vogt also mentioned, when I was trying to find a picture to describe something sexual, sensual, I could not find anything if not someone or two people or more healthy, beautiful, and young. But unfortunately, these are very perfectionistic or reductionistic view of this. We know that we're not all blessed with these criteria. And of course, these are not necessary criteria to have pleasurable sex. So I thought this is the only image that I could associate with sensuality and sex, but in reality, it doesn't really tell anything about the age, I would say. And this is a model that I work on. When we are presented with a sexual stimulus, we usually are expected, or it generally elicits specific sexual excitement, certain readiness to accommodate the sexual stimulus. And this will lead to approach. So you focus on the sexual stimulus, then you approach, and you can feel the reward. This is a healthy loop. However, a sexual stimulus can also lead to disgust, for example, or other negative emotions. And when you are experiencing these negative emotions, you cannot focus on the sexual stimulus. So what happens? You avoid or freeze. So you cannot melt, you cannot enjoy and accommodate the sexual stimulus. And I did a number of experimental designs to test this model. So for example, when you induce sexual arousal in women, so when you make women watch pornography, for example, and they are sexually excited, then they approach disgusting stimuli that if they are not sexually aroused, they would not touch these stimuli. And the same is true for men. For example, women that were sexually aroused versus women that were not sexually aroused would have sipped from a glass of water with a cockroach in it. So we are able to approach disgusting stimuli, for instance. So in reality, when you think about it, sex is quite disgusting. Just if you don't believe me in this, imagine for a moment, saliva, sweat, semen, body fluids, body odors, these are really disgusting stimuli. Why we do have sex? It's really dangerous. But apparently, most of the people, at least that's what I hear, have specific or interest in sexual appetite. They want to have sex. And what happens is then when we are ready to accommodate a sexual stimulus, somehow the sexual arousal suppresses the negative emotions, anxiety, fear, disgust, etc. And Meston and Buss tried to understand why people have sex, because it's so dangerous, why we actually have sex, right? And they understood, or they found out that there were a number of reasons, 237 reasons why people have sex. And I'm not sure if they are very clear there, but generally you feel attracted to a person, you want to feel good, you want to feel whole. and the many other reasons. But one important cluster of reasons, or a number of reasons that clustered around one topic, was intimacy. So this highlights the fact that sex is not about orgasm only or about intercourse only. And this is very important for patients who are going through cancer or are after cancer treatment and their partners. So sex should not be viewed as a performance sport, because it's not a performance sport. Sexuality, as it was stated in the first lecture, it says about our identity. It's a whole. We need to see it more than just the act of the doing, so to say. And sex means different things for different people. So as you can imagine, all cancers have an impact on the psychology of the person. If you are tired, the actual news that you have cancer will impact the accommodating feelings you have for the sexual stimulus. However, specific cancers may dampen the sexual response cycle that we heard about in the first lecture more than others. Moreover, specific cancers, like for example breast cancer, if you remove part of your erotic zone, and there are body modifications, the fact that your body change, it's quite drastic. Even if we lose weight or we gain weight, that will have an effect how we relate to our sexuality, how accommodating we are to being ready for sex. And when our partner changes, for example, it could also be that we, instead of having sexual arousal towards this person, we might also experience disgust. And we might experience disgust also towards our own body. There is what it's called, the concept that is now being discussed a lot. It's called self-disgust. And this is when you feel self-repugnance between what you want to be and what you are in reality. So the gap that there is between how you see yourself and your ideal self. However, because sex means something different to everybody, it could also be that cancer has a positive effect on our sexuality. Of course, this is not what you expect. But some people, when they are going through cancer or after cancer, they feel they want to do it more, to feel that they are alive. Or they want to, they had a very bad relationship, and now that they are post-cancer, they feel now they have a second chance, and they want to have a better relationship, perhaps. And the psychological impact, it's also different for someone who is in a relationship that is stable, that they knew each other with the problems perhaps that they had overcame already, versus someone who is single, who of course they also feel they have their own needs, their sexual needs, because we are sexual beings, but that they have also additional fears, for example, related to fertility or attraction, that they feel now they are not attractive enough to attract a partner. And practical issues, all the problems that I mentioned are also practical problems, but apart from that, they are also relating to the career of the person, to the financial situation of the person, how to deal with the children, for example, when you are tired, for example, during chemotherapy or radiotherapy, that you feel you don't have energy, and if you don't have energy, sometimes even after a day of hard work, you feel you don't want to think of sex. Imagine if you have this apathy that you don't have energy to put on makeup, for example, and to feel sensual as a sensual being. So as I said, body image, the problem of the body image might affect the patient's self-concept or the client's self-concept, but also how we feel about sex in general, and the perception and the arousal of the partner. So these are images that in reality are associated with cancer. And as you can imagine, if for a person that has pride or give importance to her body, and I think most people, this is the sort, so to say, the temple that we live in, our body is important. If you associate, for example, breast to be an important aspect of your body, and then you have a surgery that removes this erotic zone, it's quite drastic for the person. So we need to learn how to accommodate this new body, this new image of us. So some people, for example, use exposure, and we know that exposure is a very good intervention to reduce both fear, disgust, and the most intense emotions. And exposure can be either, for example, by the person screening themselves and allowing to feel the pain and this raw image of themselves. And after a while, though it's very discomforting in the beginning, when you see yourself and you start accommodating the new image, so to say, after a while the discomfort starts reducing. And we know that fear decreases quite quickly, but disgust lingers a lot. And we might not have a word for disgust. We don't use it that often, but this is an emotion that is very raw for patients that have a new body image or a modification to their body. And some patients also find helpful that they use what we call cognitive reorientation. For example, they have a scar, and they make a cognitive switch in the sense that they say, for example, this scar is sort of makes me proud because I survived. This is a sign of survival, that I'm still here, and I won over cancer, for instance. And negative emotionality, as you can imagine, there are so many emotions that are affecting the psychology of that person. So just to mention a bit more about disgust, maybe I seem a bit obsessed with this emotion, but most of my research is on disgust. So disgust is one of the most strong and primitive negative emotions that functions as a protective mechanism against pathogens, in the sense that the body organs that are in the mechanism of protecting us from contamination in the environment lie mostly on our outer body. So, for example, the vagina, the mouth, the tip of the penis, these are the highest strong disgust potent when on somebody else, and of high disgust contamination when on our own body. And as I said, disgust, the body organs at the core of sexuality are extremely disgusting. And cancer might change the body in a way that can elicit this very strong negative emotion. So, about the interventions, I think the most basic psychological intervention that can be applied to all kinds of cancers, but not only cancers, is psychoeducation. The most important, I would say, is to break the myths that, for example, a man should be ready to have sex all the time. Imagine when you have prostate cancer and you have the treatment, as testosterone will be reduced, as we also heard in the first presentation. You are not ready for sex. And if you are aware that, as any other person, it's okay not to be ready for sex, that it's totally different, then you have the expectation, then I'm not a man anymore because I don't feel like having sex. But also other myths that, for example, you should be ready for sex all the time, or you should be beautiful, or you should have the perfect body to be able to have proper sex, or that you have to have an erection every time. So enhancing sexual awareness, intimacy, focusing on sensuality, having long butts, relaxing, trying to accommodate the new body will all help also in things like cancer. And cognitive restructuring is what I said before. It's to give you a very unrelated example. For example, a person might see milk and smells that it's rotten, and then she realizes that it's yogurt, and then it's not disgusting anymore. It's not fearful if she had to take a sip. So actually, it's this cognitive switch that we can use also when I said that a scar can be also seen as something positive. And exposure, I also mentioned it briefly. And the take-home message would be, cancer is indeed a devastating disease, yet there are many survivors and their partners that are still alive. So this is important to focus on. Sex is a core business of many people's life with a positive impact on the quality of life. So therefore, it is our responsibility of all the members of the multidisciplinary team, I would say, to come together to use a filter to improve the quality of these millions and millions of people. Thank you very much.